It's a brief educational presentation, sort of summarizing where we are in the CAR T cell field in terms of toxicity management. Over the last 5 years or so, I think there have been a lot of improvements. For one thing, I think we're all just treating more CAR T cell patients because not only has there been an explosion of clinical trials, but also now in the US, there are 5 US FDA approved commercially available CAR T cell products. So that's allowed everyone to gain just much more experience using this unique sort of therapy. And as you said, they're both short-term and long-term toxicities. And a point of my brief talk is really to talk about both of those and sort of contrast those. So in the short term, we've got cytokine release syndrome and neurologic toxicity, which is increasingly being referred to as ICANs. I think that we've done a much better job in terms of having better supportive care for these patients, knowing when to transition to intensive care in many situations, just being able to recognize the toxicities. We also now have a increasingly adopted universal grading system that was published in ASBMT back in 2019, which I think has been very helpful. And the long term will be helpful because clinical trial results will be much more comparable using that grading system for CRS and a separate grading system for ICANs. And I think we're becoming much more comfortable with using various forms of immunosuppression, such as tocilizumab and corticosteroids for various toxicities, knowing when to use them, in many cases using them earlier than perhaps we were 5 or 6 years ago, and then also trying to use them sparingly enough to control toxicity, but hopefully not enough to decrease anti-malignancy response, especially in the situation of avoiding very high-dose corticosteroids whenever possible. Early on in the CAR T cell field, perhaps we had less appreciation for the long-term toxicities, but for anti-CD19 B cells, CAR T cells, long-term B cell aplasia has really been an issue, and patients often need immunoglobulin replacement therapy, which can be expensive and inconvenient for patients and also cause infusional reactions. But I think has probably helped in the long term in terms of supporting our patients who are at increased risk of infection because of their B cell aplasia and hypergammaglobulinemia. I think we're increasingly recognizing that these patients who receive lymphodepletion chemotherapy and then CAR T cell infusion are at increased risk of infection for many different reasons. And that's something we have to monitor long term. And again, some cases give immunoglobulin replacement therapy. And then we're also recognizing that a lot of these CAR T cell products, a good proportion of patients will have long-term cytopenias lasting more than a month after CAR T cell infusion, which we have to be very careful to monitor and also treat supportively. And then, a last toxicity I talk about a little bit is graft versus host disease. Even in patients who have had, prior allogeneic stem cell transplant, I think the rates of graft versus host disease have been very manageable. And when patients who have, low or no baseline graft versus host disease then get CAR T cell infusion, most of them are not having severe graft versus host disease after CAR T cell infusion. But that's increasingly a concern as we more and more in clinical trials, groups are testing allogeneic CAR T cells that are derived from healthy, unrelated donors. Even in patients who have not had an allogeneic stem cell transplant in the past, they are potentially at a risk of graft versus host disease. So that's something we have to look at really carefully in the future as there are more of these allogeneic sort of universal donor products that are tested.